Welcome to the new Ortho Info podcast, a monthly series where board-certified orthopedic surgeons provide in-depth answers to frequently asked questions about bone and joint conditions, treatments, injury prevention, and more.
Welcome to the Ortho Info podcast. I'm Dr. Sharif Bashai, a shoulder and sports medicine surgeon with the Detroit Orthopedic Institute. Each episode of the Ortho Info podcast answers a different question that we have as orthopedic surgeons heard from our patients. And this one is about rotator cuff injuries and repairs and what do we do and good options. And so I have my dear friend, Dr. Daniel Acevedo, a shoulder and elbow surgeon with Los Angeles Orthopedic Surgery Specialists. Dr. Acevedo has authored numerous peer-reviewed articles, book chapters, and surgical training videos focused on shoulder and elbow surgery. His special interests include biologic augmentation for rotator cuff repair and treating both competitive and recreational athletes. So, Daniel, welcome to the Ortho Info podcast.
Thanks for having me on, man. It was a pleasure.
So, let's start from the beginning. Why are you a shoulder and elbow surgeon?
Oh, man, that goes way back. So, look, I grew up my dad was a first-generation doctor. He worked in the ER. So it all came down. He used to take me to work, try to make me an ER doctor. And then I saw the ortho guys, and I thought they were pretty cool. I touched base with Rafi Mirzayan, and he became a mentor when I was a young medical student. And the first surgery that I ever saw in orthopedics was a Tommy John surgery. And I saw him do a Tommy John surgery, and I thought it was the coolest thing ever. And we were talking about baseball and athletes and how sports medicine came about. And then I was locked into ortho. And then during my USC training, I met up with one of my other mentors and really good friends, Dr. John Ademura, and saw him do the craziest shoulder surgeries. And I wanted to be like him, for better or for worse. So then I ended up going into shoulder and elbow. And I still do a little bit of sports medicine, like ACLs and stuff. But I wanted to focus more on the shoulder and less on the knee.
Yep. So it's funny. I'm sports trained, but I meandered towards the shoulder, and I just love it.
I think they're both great. I love ACLs. Yeah. That's one of the best surgeries to do, and it's so fun.
Let's not get ahead of ourselves. That's a whole different episode. Let's just talk to our listeners who, these are many of our patients that are listening, and we see a lot of these shoulder injuries in our practice. We see rotator cuff tears, labral tears, dislocations. And some of our listeners may have already been diagnosed with a rotator cuff tear, but may be experiencing continued shoulder pain and wondering what is the right thing to do. I know 20 years ago we would have said, oh, you can live with a rotator cuff tear. And now all of a sudden we're starting to see the issues with that decision. You want to go into that a little bit?
Let's just talk about the types of rotator cuff tears, because I think that makes a difference, right? So There's degenerative rotator cuff tears, which are age-related. You're thinking more patients in your 60s. Then there's overuse injuries to the rotator cuff. We're thinking baseball players, overhead athletes, tennis players. They're getting more partial thickness tears. And then there's traumatic, which I rarely see outside of a fall, but maybe car accidents, CrossFit injuries, you name it. So I guess it really depends on when I see a patient, is it a symptomatic tear or an asymptomatic tear? And obviously, if you're seeing the patient, it's symptomatic, meaning it's hurting. So that's the main thing. And then it also depends on the age, because we know, like with an older patient, let's say they're in their 60s, it's probably degenerative. If you're 66 years old, there's a 50% likelihood that you have a bilateral rotator cuff tear and don't even know it. And people always ask me why, and I always tell them, look, your rotator cuff's like a tire. The older you get, the longer you drove it, the more likely it is to tear. So a lot of patients don't have pain. And most likely it's because they either have less inflammation or they're able to compensate with their intact rotator cuff muscles. So if they have pain, that's when I recommend some kind of treatment.
Which is, great. And we'll get into the treatments in a second. But yeah, I think that in 2026, we've had a little bit of a shift in how we treat these. Whereas, when I first started trading before the dawn of the 2000s, it was, if you had a tear, you many times just went to therapy, maybe had a shot. But as we're seeing now, 25, 26 years later, is many of these patients are going on to need bigger surgeries like replacements. And so how do we prevent that from happening? Because that's a question I often get is, okay, if I do this, am I going to be back to normal? And I always say, well, when you wreck your car, is your car, when it's rebuilt, back to normal? No, it's drivable, and hopefully you went to a good body shop and they did a really good job and you could barely tell. but it's always different because there's been two insults. There's the injury and then, of course, the surgery. And so what do we do to prevent further surgeries down the line?
So that's a hard question. We jumped ahead. I think, so let's go back. Let's go backwards for the patient. So there's a rotator cuff tear. The tendon is full thickness tear. That means the tendon is off the bone. If the tendon's not attached to the bone, the muscle is going to continue to contract, and that's why they get retraction. So over time, we know that they don't heal, and about 50% of them increase in size in 2 to 5 years. So if they're getting bigger, the bigger they get, the less likely they are to heal. The bigger they get and the longer they go around, then the muscle becomes atrophic and it's less likely to heal. So yes, the patient will get worse. However, I still think we don't know why some patients can live with a small full thickness tear for a long time and maybe not have any issues. So again, I do still think that if it's symptomatic, you should offer them treatment. And sometimes those patients need surgery. And if it's not symptomatic, we're still not offering surgery to those patients, even though we know that the natural history is that they're going to get bigger. So to try to prevent those bigger surgeries, that's a hard question because we really still don't know which cuff tears should be fixed and which shouldn't be fixed outside of the fact that the patient has pain. So I think that's a hard question to answer. I don't know if it's preventable. The only way to prevent it is not to age, and we know the alternative is aging. So I don't know.
We don't want to do that.
That's a good alternative.
No, we don't want to do that.
Yeah.
All right. So let's talk a little bit. Some people will come in and have rotator cuff symptoms, but have good strength. And we tell them they have tendonitis or bursitis or impingement syndrome or things like that. They're all synonymous. You want to walk us through that?
Okay. So a patient comes in, they're 50, 60 plus. They have painful abduction. Usually patients have pain at night when they're sleeping. They have pain with lifting. They have good strength on their exam. Depending on their age, they likely have a rotator cuff tear the older they are. And I tell them that. So I don't usually jump to get an MRI in the beginning because I want to see if I can treat them conservatively. And I always recommend physical therapy because physical therapy has been shown, and especially in Dr. Kuhn's study, to be beneficial, and patients can have return to function and low symptoms. And then I tell them, look, if you do therapy and the pain comes back or it's not getting better, then you probably more likely have a symptomatic tear that needs to be fixed. And whether that's a partial tear or a full thickness tear, the persistence of pain for me is an indicator that I'm probably going to need to do some kind of surgery, and then I get an MRI. And then so backwards a little bit, when I see the patient, I offer them some kind of an injection. Now, the standard was before to give cortisone shots. I don't have a really big negative to cortisone. However, I do recommend not doing a lot of cortisone shots because we do know that the more cortisone shots you get, it starts to affect the mechanical integrity of the tendon. So I always say a one and done. I don't think a one-time shot is really going to affect the patient. And then after, if they still have persistent pain and we delineate the kind of tear they have, if they have a partial tear or maybe a small full thickness tear, offer them some kind of biologic therapy. So I'm really into PRP, platelet-rich plasma, and I think that can help with the pain and inflammation. But I also tell them, look, this is not going to heal your tendon, okay? So then if that patient continues to have pain, they tried an injection, they tried physical therapy, and they have a tear, whether it's a partial tear or a full tear, we know that the persistence of pain usually means that there's probably some tear progression. And then I start to talk to them about surgery.
No, that's great. And I think the conversation about steroids is really important. And, it's funny, I'll get patients that'll say, hey, I want a steroid, but not a cortisone shot. And I'll be like, they're the same thing. And so it's because
it's like a break and a fracture. No,
yeah.
The doctor said it wasn't broken, it's fractured.
And so it's Dr. Google sometimes can confuse people. So I think it's important that we understand that they're the same things. And like you said, I'm the same. I'm a one and done on the injections because, again, cortisone can be erosive and beat up on that tendon and increase your infection rate if and when we go to surgery. And so there's a lot of variables that, we want to be conservative. We want to keep people out of the operating room. However, if with persistent pain and the shot and the therapy and the anti-inflammatories and the ice and the PRP and all these things don't work, we obviously have to go on to the next step. So let's assume that this patient now comes in and has a tear. You got the MRI. And let's talk about, are there different options for partial versus full thickness complete tears for rotator cuffs?
So in 2026, a partial thickness tear with persistent pain, failed conservative management, for me, I'm going to offer that patient surgery. Now, back in the day, we used to just do what's called a debridement, where we'd go in and clean it up. Maybe we'd shave down a bone spur, which we know as subacromial decompression, but the patient always says they shave down a bone spur. That works somewhat. I don't really buy into that anymore because we don't actually do anything to the tendon. We just clean it up. We didn't change the natural history of the actual disease. So now for a partial thickness tear, I actually repair it. There's been a study by Keener where he actually did a takedown and repair and showed good results where you complete the tear and fix it. And I think that's a good option. However, that puts you at risk for not healing it because you just made a full tear. So nowadays, I offer them a rotator cuff repair with some kind of biologic implant. So there's many biologic implants available. There's dermal allograft, there's bovine allograft, there's a collagen implant that people use. And I use this collagen implant where I actually repair the tendon, and there's been some studies to show that it can actually increase the thickness of the tendon by a few millimeters. So in essence, I fix it. And I think that the patients buy into that for the biological reasons, and I've actually had good results with that. And then if they have so that's the new thing for partial thickness tears that I haven't done when I was in training that I do now.
Yeah, and I would agree with you that that's a new thing. And it's funny, we say new thing, but it takes time for things to get quote unquote new in orthopedics and in medicine. So I think that got to the US in 2014. I actually had that implant in my shoulder in 2018. So I'm a big fan of it because I had a partial tear, and I, with my line of work and needing my arms, and let's be very clear, we are laborers and we're lifting patients, moving patients, using our arms throughout the day. And it's important that our shoulders work. So for me, that biologic implant was great. And I agree with you. Why take something down and make it into a full thickness tear if it's only partially torn? So if, again, going back to that car analogy, would I rip the whole front of the end of the car off to just fix one piece of it? It's really interesting how things have changed. And I think over the next 20, 30 years, we're going to see increasing biologic types of repairs for these types of things. Now, let's jump ahead now. It's not a partial thickness. It's a full thickness tear. And I'm going to ask you two questions. Number one, what do we do? But even before that, do these patients show up in the clinic a bit different? Do they present differently between a partial tear and a full thickness tear?
I'll be honest. Unless the patient has a big full thickness tear and they come in and they can't lift up their arm, you can't tell. Mm-hmm. They look the same, especially in a young guy like you, early 50s. They come in, they got pain with rotator cuff testing, maybe trace weakness, but it's hard to tell. And I've been surprised. And, I use the ultrasound pretty readily in my practice just for a quick look to check if there's a full thickness tear. And a lot of times they'll have a full thickness tear and they have full strength that you would have totally missed it per se. But that's why I always tell patients, you may still have a tear. I may not be missing it, but if they have good function, they have good strength, I still think a trial of non-operative management is going to be the way to go. And if you have an ultrasound, you can check real quick and tell them. Like I said, I don't over-order MRIs unless the patient really wants it because I already kind of know what I'm going to see. And I don't think that it's really going to change my initial management, but I do get it for patients sometimes. Or if I'm really concerned, like if they have overt weakness, I'm thinking they're probably going to need surgery. So I just want to get some more information so I can counsel them better.
And I think that MRI is so helpful for preoperative planning and knowing how big the tear is, what kind of, there's different ways to fix it. We'll get into that shortly. And so it does help you understand what are the chances of this healing versus not healing and so on. And, with our listeners, is how do you tell them that, or when they come in, it's funny, when they give me their history, I almost can answer immediately what they have just because of the
50-year-old smoker,
Yep.
can't sleep at night.
Rotator cuff.
Hurts to lift, rotator cuff tear, right?
Yeah. And their pain will be on the outside of the arm. Yep. They always say, it's over the outside of my arm. Never goes past the elbow.
Yep.
If it goes past the elbow,
it's the neck.
What is that?
It's
there
the
it
neck.
is.
It's usually the neck. However, for the listeners, it's weird. A lot of patients who have a shoulder impingement, partial tear, maybe even a full tear, but more so just a shoulder impingement, they always get tennis elbows. So you got to look at the elbow too, because they get tennis elbows and they might have two things. It's not just one thing.
And things compound. And so sometimes going back to what we started talking about, let's try to treat people non-operatively, but if things are hurting downstream and you're now getting elbow pain and wrist pain and you can't move your shoulder. It's, the writing's on the wall, so it might be time to do something. All right, so let's move on. When do we see a doctor? So all these people are coming in and they're saying, oh, my shoulder hurts. Now, what do you tell the patient?
I had one guy came in. He came in on Thursday. I'm like, when'd your shoulder start hurting? He said, Monday. So I said, okay. So then I told him, this is good information. Look, 2 weeks is a good number, right? We're getting older. I think people need to realize that you wake up with pain sometimes, you sleep on it funny, maybe you did something at work. And a trial of just rest, ice, and anti-inflammatories at home isn't a bad idea for a week or two. If you have something that's bothering you for more than 2 weeks, it hasn't gone away, you have shoulder pain, it's going to your mid-arm, you're having trouble sleeping, that's when you should see a doctor, because you don't want that to get worse. You either have an impingement, you could be developing a frozen shoulder, or you have a rotator cuff tear, and that's just something you want to know.
There you go. Now, here's the real question. There's a lot of redundancy with healthcare. So you're a shoulder and elbow surgeon. I'm a sports surgeon, but do a lot of shoulder. Then there is the general orthopedist. And then there's the non-operative family practice sports medicine fellowship trained person. Who is the person to see?
So that's hard to say. I think all of our colleagues are very good, and I think that they're getting trained, they're cross-trained, right? These primary care sports medicine guys do orthopedic rotations, and they learn how to do a good shoulder exam. It really just depends on how much shoulder pathology they see, but I think most people have a general idea of what can cause shoulder pain and get you an initial diagnosis. I have patients who want to see a shoulder specialist because those are the type of people that they are. That's fine. So come see me. I don't mind seeing non-operative things. But I think, if you see a primary care sports medicine doctor, anybody sports medicine trained, or a shoulder and elbow specialist, any one of those people can give you an initial diagnosis. Now, the question comes to okay, do they know at what point they pull the trigger to offer somebody surgery? So, I do have a bias, and that's why I think that I don't mind seeing the non-operative patients, because I have the gamut. I can treat you non-operatively with therapy. I do biologic therapies. I do surgery. And I can really tell you as a patient what you're looking at long-term and when to pull the trigger on certain things, like having a surgery. So I think it just depends. But I think going to see a doctor, at least somebody trained in medicine, even a therapist, there's some therapists that I work with that are very good, and they come in and say, my therapist says he thinks I have a rotator cuff tear. And I go, okay. And I'll see the patient. And, some of the times it's right. Some of the times they have a frozen shoulder, but at least they knew to refer them to a doctor to go get evaluated. So I think between a physical therapist, a primary care sports doctor, or anybody who's an orthopedic surgeon, even a general orthopedic surgeon, as long as they're an orthopedic surgeon, would be a good person to go look at your shoulder.
Yeah, I think that's a great answer, because it depends where you live. And I'm in Detroit, you're in Los Angeles, big cities with lots of specialists. But if you live in rural areas, you're going to have a general orthopedist who's probably going to be the same person who's going to do a total knee on a patient, do shoulders, do carpal tunnels, very well trained, but they still have to do a little bit of everything because there's just not as much saturation of orthopedic surgeons there. But I agree with you. The gamut is the most important thing. You got to be a little bit careful going to some places where they don't offer everything. And if they don't, there's also some very good non-operative type physicians that will immediately know that it's time to send it to the surgeon. But then there's some others that will keep it and give multiple injections. And so we got to be a little bit careful. So if you're receiving your third or fourth injection, it's probably time to see a surgeon.
Maybe after the second injection, because 3 or 4 is a lot.
Okay, fine. I agree with you. I was just trying to be nice. But I think that there's definitely a place where you have to get all your options, and with that, see where it goes. All right. Are there any red flag symptoms that you're like, oh my gosh, this is a problem? Like when you see a patient?
So the main thing, red flag is stiffness. People can get a frozen shoulder, even with a rotator cuff tear, more likely with a partial thickness tear. A lot of patients get frozen shoulders and get misdiagnosed as having a partial thickness tear and actually just have a frozen shoulder. So stiffness and pain is one. Pain in the middle of the night. So once you start having night pain with your shoulder, a lot of shoulder pathology causes night pain, but I think once you have night pain, you start affecting your sleep. That's going to affect your mental health. It's going to affect a lot of things. So I'm really big on the sleep. So if it's starting to affect your sleep, go see somebody. And the next thing is like just inability to lift up your arm. If you fell or you were at work one day and now you can't lift up your arm, that's a good reason to get seen to make sure you don't have a rotator cuff tear or a frozen shoulder. And then numbness and tingling in the arm, that's a good reason to be seen. It's probably not a rotator cuff tear, but definitely should be seen for numbness and tingling. It could be some kind of neck problem or carpal tunnel syndrome or something, but definitely those things are the most likely reasons why patients will come in with shoulder pain. It's either I can't lift my arm, I can't sleep at night, I have shooting pain down to my arm, my hand, or whatever.
Yeah, I will agree with you. The mental health component is real. I know that my wife did not like me when I had a rotator cuff tear as much as she does now, because you just don't realize how irritated you are just because you're living in pain. And I probably prolonged mine a bit too long, but she loves me now because I'm so nice. And that's because my shoulder doesn't hurt anymore. But let's talk a little bit about, we get a lot of patients that are sent to us for shoulder and it's their neck. Like, how do you differentiate the two? I know you started talking a little bit about the numbness and tingling, but they're so intimately related that it's like, how do you separate the two, or could it be both?
So yeah, that's very common and very difficult, not difficult, but it's tricky. So a lot of patients will have trapezius pain, and I call that the middleman. And it's either you have a trapezius strain, or you have referred pain from your neck, or you're compensating with your shoulder because your shoulder's messed up and it's causing your trapezius to hurt. So that's the hard one right there, because everybody has trapezius pain right here in the upper trap. And then, I do a neck exam on most patients who have shoulder pain, and I check their neck range of motion, and then I check a Sperling's test, which is when I have them lean their head back and see if that causes any shooting pain down the arm. And then you have to do a good shoulder exam and really delineate it and see which one hurts more. And then as far as who has both, yeah, if they're having neck pain, I'll get neck x-rays, and sometimes they have neck arthritis, but then they also have shoulder problems. That is where you really need to see somebody who knows what they're doing. And I would probably defer to a shoulder specialist, or even a lot of our spine colleagues are really good and we'll send patients, they say, no, it's not your neck, it's actually your shoulder. And I'll get patients that way too. So that's where it really comes in, where you got to see a specialist.
Yeah, I agree. All right. So we've talked a lot about non-surgical treatments. We talked about therapy, injections, biologics, anti-inflammatories, ice, heat, activity modification, all the things that we try first, and it doesn't work. And so what is the next step? But I think it's also really important that quite a few people do get better with non-operative treatment. But did their rotator cuff heal?
No.
Exactly. So you can live with a rotator cuff tear, but eventually, like you said, 50% of these will get bigger and it'll become more symptomatic. So that's one thing I always tell them with non-surgical treatment is you may have dodged the bullet now, but I don't know what the future holds. It could, if it comes back and it gets worse, then we're going to talk differently. So I always see them, even when they say, I'm feeling great. I said, I'll see you in 3 months.
Yep.
And when they come back in 3 months, if they still feel good, then I'm like, all right, call me if you need me. But if they're turning the corner, unfortunately for the worst, that's when we start going down. Okay, here are the surgeries we're going to talk about. So why don't we jump into surgical treatments, and what are our different options here?
So back up real quick. So I had a patient last week. I saw him a year ago. Shoulder pain, partial thickness tear on the MRI, gave him an injection, sent him to physical therapy, did well for a year. And I tell them what I tell everybody: look, if your pain comes back, we know that based on the natural history studies, that usually indicates tear progression. That usually means it's getting bigger and you probably should get it fixed. The guy came back, said the same thing, got an MRI, and it progressed to a full thickness tear. So now I'm talking to him about surgery because it got bigger from a partial thickness tear to a full thickness tear in 1 year. The pain came back after conservative management. So he did the exact right thing. What I think that all patients listening to this podcast should do is, look, if you do well with non-operative treatment and the pain comes back, don't ignore it. That usually means it's getting worse, and you're going to have to hit it on the head at some point. But this is where we talk about preventing further surgeries. Is if you're young, less than 70, you're healthy, you're not a smoker, you're active, and you have a tear that's fixable, that's small or medium, there's no atrophy on the MRI, and the doctor's recommending surgery, I think that patient has a really high chance of healing their tear and getting a good outcome. And if you don't do that and you let it ride and you roll the dice, in 4 or 5 years, that may be big. And I had a patient like that too. And now we're doing not a shoulder replacement, but we're going to do some kind of a tendon transfer. Fun surgery for me, not as fun for the patient. Patient could still do well. They're not going to be an A plus. Maybe they're going to be an A minus, right? When if you fixed your tear and you healed it, you could have been an A plus student. So those are the things to think about. So now we're getting to surgery. So if you have a full thickness tear, we're doing arthroscopic rotator cuff repairs, which hasn't really changed over the years since I've been training, and probably not since you've been training. We typically do what's called the double row repair these days, where we do anchors on the humeral head, and then we do a little crisscross suturing, and we suture it down to another row of anchors to offer good compression to the tendon. And I think that's been shown to have a higher healing rate with bigger tears. And that's my move to do when I do surgery. Now we've actually added more biologic therapies, because we know that if you spend a little bit money up front, we save money on the back end. So what my wife taught me is that cheap is expensive. At least that's what she says.
She's not wrong.
So if you have risk factors, so I don't know, do you use the Rohe score in your?
I was actually going to ask you about the Rohe score, so go ahead.
So there's this new thing called the Rohe score, the Rotator Cuff Healing Index, and it brings in age, size of the tear, bone density, etc. There's a bunch of little scores, and I put it into the computer because I'm not that smart. I'm an orthopedic surgeon, and it gives me a number. And if the number is high, above 7, it's unlikely going to heal. However, if I'm planning to fix it, I can do some things to kind of improve that healing. We now on the CPG guidelines for AAOS, they actually recommend putting a collagen biologic implant to improve healing. And now there's other implants too, so they all can help. So I've been using these implants for high-risk patients to improve my healing rate and actually decrease the re-tear rate. Additionally, I also talk to patients about doing add-ons, I call them. So there's PRP and there's BMAC. So we talked about PRP, but there's BMAC. What's BMAC stand for, Sharif?
Bone marrow aspirate concentrate, or bone marrow aspirate.
So I don't know how to explain it to the layman, but what I call it is, I say it's like a dirty stem cell. It's a biologic therapy with mesenchymal cells that are going to try to help stimulate healing. And I've been doing a lot of add-ons lately, mainly PRP, where I actually, after I do the repair, I'll stick the PRP on top of the repair and in some of the tendon to try to incorporate some biologics. And then the last thing that I've been doing as of recent, due to my interest in just working out and also the evidence coming forth, is nutritional supplementation. And I know you've been using that too, right, Sharif?
Yes, sir.
So there's been a lot of evidence that amino acid supplementation can actually improve collagen deposition, decrease wound healing infections, decrease length of stay in all areas of orthopedics. So routinely when I do surgery now, and I like to say I have to give credit to Scott Sigmund, but I do act more as a biologist. And I try to have a conversation to the patient about how your body, the host, is really going to be the main thing that's going to help with the healing, not really my surgery, because we know me and you are both good surgeons, and we can do 10 patients and I'll have 3 that don't heal, you'll have 8 that don't heal, and we don't know why.
Why do I have more that didn't heal?
That was a jab. No,
I know.
But yeah, so those are the things I'm talking to patients about now.
What are those factors that you're worried about? I know for me, it's you often tell a patient, hey, you're a smoker, you need to stop doing that. Do you want to go into a little bit about smoking and diabetes? Because this is the most common.
So smoking, a lot of people don't know. Smoking, this includes vape, chewing tobacco, Zins.
Any nicotine.
The nicotine is a vasoconstrictor, and it closes off small blood vessels first. So that's why people get heart attacks. Okay, that's a bad thing. But those small blood vessels actually feed the rotator cuff from the bone to the tendon, and in our terms, we call it the emphysis. So if those blood vessels constrict, then the tendinous tissue is not getting good blood flow, and it'll just die and start to tear with any nicotine use. And if you're having a rotator cuff repair and you're still using nicotine, there's a 65% chance that you won't heal. So I do have that nicotine conversation, and I try not to belabor it, but I tell patients, I'm like, look, you're going to go through this 6-month recovery. You don't want it to be for nothing. So I've had patients stop smoking I know that there's some doctors who actually will get nicotine blood tests and until they're clean, won't do their surgery. I haven't done that yet. I just am trusting the patients. Luckily, in Los Angeles, where I live, smoking is not really a thing. Vaping is a thing for kids, but I have met like middle-aged people who do these nicotine pouches, and I have conversations with them about that. And then as far as the diabetes goes, I mean, we just know if your diabetes is out of control, those sugars in your bloodstream that's causing havoc on most of your organs also cause havoc on the healing, like the hyperglycemia. Those, they're called glycosylated end products, can actually go into your tendon and affect the healing. Just it affects your white blood cells, so it can increase your chance of infection.
I couldn't agree more. I think if you went back 15, 20 years, we'd be arguing on like how many anchors we should use, what kind of suture we should use. And to be very honest, I think we've cleared up that really doesn't make a huge difference. It's the host, and it's all these parts and pieces of the body and the blood and the cholesterol and all these things that make a huge difference in whether things heal or don't heal. All right, now we're talking surgery, and first thing the patient says is, "Oh my God, surgery is so painful. I heard it's just the worst." What do you say to that?
So I tell them that everybody's different. I don't have that experience anymore. I use multimodal analgesia now and an opioid-sparing pain regimen. So everybody in my practice gets an interscalene block, and I think that really helps. It lasts for 24 hours. They get less anesthesia, less narcotics. They wake up with their arm numb. And then what I tell them is like, look, you got 24 hours where your arm's numb. That gives me 24 hours to jump on the pain and start the pain regimen so that the transition is smooth. And that's usually the case, right? I do like over 250 cuffs a year. I maybe I'll say 5% where they're like miserable for like a week and they're asking me for narcotics maybe. But I rarely give a narcotic refill because I have a conversation with them where I'm opioid sparing and I talk to them. So I use an anti-inflammatory around the clock, and I'm not conflicted or anything, but I use Toradol. I use it every 8 hours around the clock for 3 days. And then I hit the nerve pain pathway. I use gabapentin typically. And then I use that at night for 2 weeks. And I think those have a synergy and it really helps them with the pain. And then I tell them for breakthrough pain, 1 through 5, you take a Tylenol. 6 through 10, maybe take the narcotic. And I only give them 10. And I always tell them, look, I have patients who can take less than 5. So I've been doing that for years. But most patients, I would tell you that the first 3 days are kind of difficult. I also give them sleeping is the main thing. I use this special pillow called the shoulder sleeper pillow, and I think that's been helping. I still like cryotherapy or having them use ice packs around the clock. I think that helps. But usually it's like the first 3 days. And then after that, I don't really have a lot of patients having a lot of pain. And then when they come in at 2 weeks, they're saying that they're sleeping okay. They're taking just Tylenol. They're off narcotics. Like I said, I rarely give a refill. So I don't think it's as bad as people make it out to be. And I don't think that people are really having that much pain anymore, but they're going to be sore for a while. They're going to have trouble sleeping for a while, for at least a couple of weeks. They might not be able to sleep on their back. By about 6 weeks, they should just be on Tylenol and sleeping normally. And then by 3 months, they should just have aches and pains with random activities and maybe take an NSAID here and there. And then it starts hurting again because they start doing strengthening. And then by 6 months, 90% of them are already at 90%. So I always tell patients, it's like falling down the stairs slowly. You'll fall down really fast in the beginning, you'll stop, then you'll go slow, and then eventually you'll get to the bottom and it'll stop hurting.
Well, that's an interesting analogy. I like it, though. Yeah, no, I think everything you said is pretty much what I do. The nerve block I use lasts for about 3 to 4 days, but it's not at every facility I go to, but I try to get it everywhere I go. And what's nice is, I think, like you said, if you can get them through the first 3 days without a significant amount of pain and hit it from multiple positions, and that's, like I said, with the Tylenol at the time of surgery and gabapentin for the nerves and a steroid to calm everything down. You give them a scopolamine patch so that they don't have nausea. All these things.
That too.
Yeah, and before you know it, they wake up and they're like, oh, my friend told me theirs was terrible. This isn't so bad.
Oh, yeah. And also, like, I think just the new drugs have helped, and just our technique, we're getting faster. Obviously, like, doing the scope under an hour and not 3 hours, right? Is going to make a difference because of the pressure from the fluid, et cetera.
Sure.
But so many things that we've learned over the years, I don't think it's as bad. I remember I was in residency and people would be screaming in the recovery room. And I was like, this is terrible. I don't have that. I haven't seen that in 13 years since I've been in practice, because I've learned so much even from you. So I just don't think that. I think patients need to talk to their doctor, and if their doctor is telling them they're going to have a lot of pain, maybe they're just not doing things right. Maybe go see another doctor. But it's not as bad as people think about it. And I just kind of talk to them about it and just make sure that they understand that they need to stay on top of it. And I can't say that I've had somebody that said, oh, I wish I never had this done. I haven't had that.
It's rare that you see that, but I will agree with you that I do remember those days of training with those patients screaming in the post-op recovery area. And I thought to myself, I never want to do shoulders when I'm in practice. And here I am. It's 90% of my practice. But I think, like you said, so many things have changed. We've learned so much. All right. Now, surgery's done. Surgery went great. Everybody is happy. Now what? What's next? I mean, are we done? The patient's going to be fine? Or what's the next big part?
So the next big part is the therapy. Now, I utilize a physical therapy app for the savvy patients that don't have time, like my business people, my CEO people, and just my fitness freaks. They can do it on their own. Okay. Then there's the other patients that need to go to physical therapy, and that's where the time comes in. So I keep patients in a sling for about 4 weeks just for healing purposes, no longer, no less. At 2 weeks, I let them do some home-based pendulum exercises. And then at 4 weeks, that's when physical therapy starts. And we start with passive range of motion. And then at 6 weeks, we do active range of motion. And so you're not even lifting up your arm for like 7 to 8 weeks. That's almost 2 months. And then at 3 months, they're usually lifting up their arm, let's say like 130 if you're doing pretty well. They can do stuff. They're back at work, light work, but they're not working with their arm. Then I give them a 10-pound limit. At 4.5 months, I give them a 20-pound limit. And then after 6 months, they're usually pretty recovered, no restrictions, and they can keep using it. But full recovery is not for a year. You're not going to be as good as it gets for 1 year. So it is a long haul. I think, and that's another thing to talk to patients is like the surgery and all that. That's the easy part. I think the recovery is the harder part. If you get patients to buy in and they want you to be happy when you see them, they work, right? They want to do a good job for their surgeons. They buy into it, but you got to prep them. This is not an easy, like, oh, I'm going to be back to work in 6 weeks. And I tell them, look, it's going to be 6 months, but it's not going to be it's all 6 months of crazy. I can't use my arm, but there is a period of 6 months where you're not going to use your arm to the full extent. So,
of course, my biggest thing is the first couple weeks of therapy, the patient is laying there and the therapist is passively moving their arm. So I always struggle with having the patient do that part on their own, because how do you passively move your arm? So this is where I think there's some dissent between surgeons. Like you said, 4 weeks in a sling, depending on the size of the tear. I'm usually 6. And if it's a partial, maybe a week. And so there's still some nuances and experience from each of us. It's not to say that I'm right and you're wrong or the opposite. It's just what works for us. And I think there are also significant geographical changes between patients. So, vitamin D is huge in the healing process. And you live in California where there's actually sunshine. Here in Michigan, we go 6 months in the dark, it feels like sometimes. And those are when people want their rotator cuffs fixed. So I think I found myself being a little bit more conservative on the rotator cuff. However, I think all in all, we're saying the same thing, that therapy is so important because you need somebody who's an expert there. And I would not tell you I'm an expert in that stuff. I'm good at what I do in the OR, in the office. But those therapists are wonderful.
They're great. And the only thing, I try to meet a lot. I don't like cherry pick my therapists, but like I have like 10 that I've actually met. I went to their facilities and I told them what my deal is, and I send patients there. Your surgeon has to know these therapists. I think that's huge, because then they know the nuances. They know what I want. And then they have my cell phone number. They can call me. And they call me all the time. And that's the kind of surgeon PT relationship that you want. You don't want to just go to this doc in the box who sends their patients to this PT in a box, and they have these protocols and no one ever talks to each other. I don't think that works. From
Agreed.
a patient perspective, if your doctor wants to send you to so-and-so therapist because they work with them a lot, that's probably a good thing. And then if you're a therapist and you want more patients, go meet the doctors and vice versa. But I think that's a big part of it too, because, you got to have this team effort to the rehab. And I think you'll have a better result if you have something like that.
Agreed. All right. So the common question we hear is, okay, what can't I do after I get my shoulder fixed?
So if it heals after 6 months and it's healed on the ultrasound, the MRI, you can do whatever you want.
I agree. But I think there's this concern out in the wild that if I have my shoulder fixed, I can never do anything again, or there's certain things I'm going to have to give up. Are there certain limitations you put on patients? Or at least
really.
In different time periods?
Yeah. After 6 months, I don't really give any restrictions. It's really going to be what they can do, right? It's like having the car analogy, like we fixed your flat, but your tires still might suck. So,
Right.
you might not be able to, like Kobe stop playing basketball, right? Or you might not be able to go back to do full level construction. You'll be able to do some level of construction work, but yeah, it's never going to be normal. So I tell patients, look, you need to adjust to your new normal, and you need to find out what that is, and then you kind of live in that new normal. But as far as like an overt restriction, I don't really give any restrictions unless the patient would ask for them for some reason.
All right. Okay, let's talk about worst case scenario. You do a great job. They do a great job. Continued pain. They come back. Weakness. It's retorn. Now what?
So then now you got to go see an orthopedic shoulder specialist, either a sports medicine doctor who does a lot of shoulder, or a shoulder and elbow specialist to kind of see your options. And that's probably another podcast, but there's a lot of options for that. They're not just going to live in pain. You're going to start to talk about like tendon transfers and shoulder replacements, but there are options for those patients, even injection therapy. So luckily that doesn't happen too often. If you're a shoulder specialist, you do see a lot of those just because you're getting them all. But there's options, but that's the time where you need to go see somebody like me or Sharif.
Yeah, I agree. And it's not to say some of the others can't do it, but I think this is what we see. That's, it's on our schedules. It's not uncommon to see revision on a day because that's what we do. But I think there's also the part here where we have to just really educate those patients. And I know for me in my clinic, we have an appointment before surgery. So we might schedule surgery, and then they come back for a preoperative appointment to go through everything, because I think the more the patient understands what's going to happen with their body and like what recovery looks like, it makes it easier for them to pre-plan and get ready for it, versus sometimes I actually saw a couple patients yesterday, which I didn't think I was spending that much time with them, but I was their third opinion. And both of them said, you spent more time with me today talking to me about my injury than the last two combined. And I was a little taken aback because, this is just my normal talk track. But I think if you're a patient and you don't feel like you've received all the information that you really understand and need, then get another opinion. It's okay. You're not going to hurt us. If anything, this is your body. We've done thousands of these procedures, but this might be the first of what you're getting. It's important for us to always be grounded with our patients and really understand what our patients need to hear so that they can feel comfortable with what we're about to do. I mean, we ask a lot of questions when we use the car analogy again. What did you do with my this? What did you do with it? These are our bodies. Why aren't we asking the same amount of questions as the consumer, as the patient? So get your answers that you want, because I think it's so important, and make sure that you have access to your surgeon and their office and their staff. Like when you try to call and see if they can, like, even make an appointment, if it takes you 15 minutes to make an appointment, God forbid you need them quickly. And, so we got to take into these considerations. What's the best for me as a patient?
Yeah.
Well, Danny, on that note, I think it's time to wrap things up. I really appreciate you coming on today. I mean, your wealth of knowledge in the rotator cuff. I mean, I also know that your nickname is the Cuff Daddy. I mean, because you're so good at these. So I want to thank you for your expertise. And again, Daniel Acevedo out in Los Angeles, California, and I'm Sharif Bashai. here in Detroit, Michigan on the new Ortho Info podcast. I hope you enjoyed this conversation and will tune in again to future episodes about different topics. Thank you.
This has been the Ortho Info Podcast, brought to you by the American Academy of Orthopedic Surgeons. Production and editing by MK Quinn Media. You can find the Ortho Info Podcast on orthoinfo.org and wherever you get your podcasts. Like and subscribe so you won't miss new episodes, and visit the Ortho Info YouTube channel for full video podcast episodes and shorts. The views and opinions expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent by the AAOS. Reference to any specific product, device, or service during this podcast is for educational purposes only and does not constitute endorsement or recommendation by the AAOS. Ortho Info. Expert musculoskeletal health information provided by surgeons, trusted by patients.